My name is Muhammad Waqar Azeem. I'm chair and professor of psychiatry at Sidra Medicine with Will Cornell Medical College in Doha, Qatar. I'm also director of WPA Collaborating Center of Sidra Medicine in Qatar. It's a real honor to present at this international conference on psychiatry in Lahore, Pakistan. I'm especially thankful to Professor Afzal Javed, Professor Nasser Saeed, Professor Imran Ijaz Haider, and Professor Khalid Mufti for organizing this very important event and giving me the opportunity to present. My topic today is an update on child and adolescent psychotic disorders, which is an extremely important area in pediatric psychiatry. So I will go through a few things in my presentation. So I will start with some case presentations. 14-year-old adolescent boy admitted to the inpatient psychiatry unit after complaining of devil's voice telling him to kill himself. He's struggling with sleep difficulties, endorsing racing thoughts, and at times being aggressive. According to the family, the youth is having these issues over the last few weeks. There is family history of mood disorders on maternal side and psychotic disorders and substance abuse on paternal side. The youth's medical history is unremarkable, except he has asthma. So in this kind of situation, what are the possible diagnoses you will think of? I hope I have more interactive session if I would have been in person in the conference, but I will still try. So some of the things to think about, since there is a family history of mood disorder, he's having these symptoms for last few weeks. You'll think about possible bipolar disorder, possible psychotic depression, possible substance abuse, some of the things to think about. Next one, psychiatry team is consulted on a 15-year-old adolescent girl who's on a pediatric floor. The girl has undergone renal transplant 6 days ago. She's having auditory hallucinations, sleep difficulties, irritability, and racing thoughts for last 4 days. She's currently taking fluoxetine 20 milligram for depression for last 1 year. So what are the possibilities? The first thing come to mind is this girl has gone through renal transplant and most likely taking immunosuppressive medications like steroids, which can be one of the reasons for psychosis. Also, there was acute surgery. So any medical reasons should be the first thing to think about. Next one, 16-year-old adolescent boy who presents to the emergency department after he tried to jump off the car, believing that he has to do that to save the president. According to the parents, for about last 8 to 9 months, he's deteriorating in function, including missing school, spending a lot of time in his room, not participating in family activities. For last couple of months, he's talking with unseen people and making gestures in air. So in this situation, the history is 9 months old and looks like he's presenting with some positive and negative symptoms of psychosis. So the first thing you think about is primary psychotic disorders. But at the same time, you can think of mood disorders or any other medical reasons for this. So these are some of the presentations. When we think about psychotic disorders, there are 3 main things we think about. First one, is it a primary psychotic disorder like schizophrenia, schizoaffective disorder, schizophreniform disorder, or delusional disorder? Or this might be mood disorder or anxiety disorders. For example, bipolar disorder, sometimes severe OCD might look like psychosis, or sometimes you see some psychotic symptoms in PTSD or borderline personality disorder. And then one of the first thing we should think in pediatric population should be the medical conditions, drugs, and anything similar. In that regard, some of the medical things you think about possible thiamine, folate, B12, or niacin deficiency can be any autoimmune disorders, some metabolic conditions like renal failure, hepatic failure, hyper or hypocalcemia, hyper or hypoglycemia, endocrine issues, especially thyroid issues, we should think about in differential. Possible infections, which can be viral, syphilis, parasitic, tumors, especially parietal or occipital lobe tumors or frontal lobe tumors, seizures, sometimes absent seizures can present with these kind of things, and medications, as I mentioned in the previous case presentation. Regarding early onset schizophrenia, same criteria is used as for adults. It's very rare in children. 0.1 to 1% of patients with schizophrenia present prior to 10 years of age. 4% present prior to 15 years of age. And then incidence increases after puberty. Peak age usually for psychotic disorder is between 15 to 30 years of age. 47% display onset prior to 21 years of age. 21% have psychotic symptoms prior to age 21. Age of onset during teens and late 20s, childhood onset is rare, as I mentioned before. Usually, boys have earlier onset than girls. Then you think about various genetic and environmental reasons and how it impacts the cognitive functioning and possible clinical presentation. A graph showing, so if you look at this, the peak is usually around 20 to 25 years of age, and then it comes down around 30, 35 years of age. So very important to think about possible age of onset. What are some of the signs of prodromal psychosis? Like when it's not full-blown psychosis, that you will see some possible things which might predict that person might develop psychosis later on. Unexplained decrease in work or school performance, like falling in grades. Decreased concentration and motivation. Person not taking care of their day-to-day activities or cleaning themselves. Decrease in the ability to cope with life events and stresses. Loss of interest in friends or sports or hobbies. Decreased sense of connection, alienation, not connecting with the family, more hostility, more paranoid. Regarding schizophrenia, so in adolescence, we think about the same symptoms, which include positive symptoms, delusions, hallucinations, disorganized speech, disorganized or catatonic behavior, or negative symptoms like affective flattening, lack of speech, lack of motivation. In schizophrenia or any other psychotic illnesses, it's very important to think about what is the impact on social and occupational functioning. Duration needs to be at least 6 months. Symptoms are not due to mood disorder or schizoaffective disorder, and not due to medical conditions or substance abuse. In autism, as you know, that usually children or adolescents struggle with speech and thoughts, so delusions or hallucinations has to be prominent. What are the key differences between DSM-4 TR and DSM-5? In DSM-4, only one symptom was needed for criteria A, especially like, for example, if delusions were bizarre or hallucinations in which two voices were conversing. That has been removed from DSM-5. Now, two symptoms are always needed from criteria A, as I mentioned before. In DSM-5, at least one of two symptoms from criteria A has to be hallucination, disorganized speech, or delusion. In DSM-4, as we know, there are a lot of categories which have been eliminated in DSM-5. So what are some of the things you think about possible risk factors? In monozygotic twins, 31 to 78% more chance than dizygotic twins to have psychotic illness. Adoption studies have shown that there's high risk of schizophrenia in children who were born to parents who have psychotic illnesses. Then there is a lot of studies done showing some changes in brain imaging, like enlargement of large ventricles, smaller than normal total brain volume, cortical atrophy, widening of third ventricle, and smaller hippocampus. As you can see in this fMRI study, on this side where my arrow is, you can see the enlarged ventricles as compared to this image. Again, these are two pictures of twins, one 35-year-old and then 28-year-old, and you can see individuals who have schizophrenia have enlarged ventricles as compared to, this is the normal imaging, this is the normal image. Then we see gray matter loss in individuals with schizophrenia. So in these images, if you see a normal adolescent, the image is all kind of blue and greenish. And in individuals or adolescents with schizophrenia, this red color is showing gray matter loss in these studies. Other than schizophrenia, what are the other psychotic disorders you think about, which are primary psychotic disorders? Schizoaffective disorder, in which you need to have a depression or mania or mixed episode with criteria A for schizophrenia. Schizophreniform disorder, where duration is the main difference, that at least 1 month up till 6 months. Then there is brief psychotic disorders, at least 1 day, but less than 1 month. And then delusional disorder, duration is less than 1 month. And then some individuals present with catatonia. Regarding mood disorders, depression and psychosis, 10 to 30% of youth with major depression can present with psychotic symptoms. In bipolar disorder, about 30% of the adolescents with bipolar disorder have a history of psychosis. Up to half of the adolescents who were originally diagnosed with schizophrenia later on found to have bipolar disorder. So when somebody presents with psychotic illnesses, it might look like primary psychotic disorder, but studies have shown later on these adolescents go on to develop bipolar disorder instead of primary psychotic illnesses. How to do a workup of new onset psychosis? The most important, history from individuals, from parents, families, schools, then the course of illness, how it was developed, acute inset, or these symptoms are going on for a duration of time. Family history of mood disorder or psychotic disorders. Physical exam, if there are any neurological issues, then possible CNS studies to think about, EEG, brain imaging, lumbar puncture if indicated. Then some of the laboratory tests which we should think about doing: liver enzyme, CBC, electrolytes, BUN on creatinine, thyroid function, urine analysis, ESR, B12, folate, HIV, and any other possible infections or medical reasons you can think of. Moving along, regarding treatment and management of schizophrenia or psychotic illnesses, the most important is that we need to find out what is the reason for psychosis, because that will drive our treatment. Then psychoeducation for the youth and family, because it's a big thing to discuss with the individual and the family about this illness. Then what kind of antipsychotic medications we use, what kind of social and educational support is needed, and then what kind of supportive or other kind of psychotherapies might be useful. In a lot of countries, still typical neuroleptics is used, and I know in Pakistan nowadays more and more we are using atypical antipsychotics, but I will still mention there are low potency antipsychotics, chlorpromazine, thyroidazine, and mesoredazine, and then high potency like Haldol, loxapine, molindone, which are available. Some of the side effects to think about: acute dystonia, Parkinsonian side effects, akathisia, that feeling of restlessness, tardive dyskinesia, which is a long-term thing, sedation, orthostasis, increased prolactin, and then neuroleptic malignant syndrome. So a lot of side effects you think with typical antipsychotics. When we are picking up any medication for psychosis or any other illness in adolescence, I think the most important thing we have to think about is what is the science behind it? Is there is evidence for these medications to use in this population? And what are the studies done showing effectiveness of these medications in children and adolescents? So what are the antipsychotics which are FDA approved in US, because there is clear evidence or studies done for their effectiveness in this population? Risperidone is approved for schizophrenia for age 13 to 17 and for bipolar disorder for age 10 to 17. And in autism for irritability, it is approved for age 5 to 16. Olanzapine is approved in adolescent age 13 to 17 and bipolar age 13 to 17. Quetiapine is approved in adolescent age 13 to 17 and then for bipolar age 10 to 17. Aripiprazole is approved like risperidone for irritability in autism for age 6 to 17 and then also approved for adolescents, schizophrenia, and bipolar disorder. And then paliperidone is approved for schizophrenia age 12 to 17 and then asenapine for bipolar age 10 to 17. So if I'm picking up a medication, I will first think about these medications for psychotic illnesses or bipolar illness in adolescent for as first line of treatment regarding antipsychotics. What were the studies done to support this evidence? For risperidone, in a 6-week randomized double-blind study done, which was placebo-controlled, age was 13 to 17 years of adolescence. The dose of risperidone used was from 1 to 3 milligram per day, or risperidone dose 4 to 6 milligram per day. So 2 types of strengths were used. And the clinical response was measured by a 20% reduction in PANSS total score. 160 adolescents participated in this study. And significant improvement were noticed in both risperidone groups, whether they took a lower dose 1 to 3 milligram or higher dose 4 to 6 milligram. So in adolescents, studies have supported that we should not go more than 6 milligram in most of the cases. And if individuals are going to respond, they are going to respond between 1 to 6 milligram. Adverse side effects were much more common in risperidone, 75 to 76% versus placebo, 54%, and with a higher dose, higher incidence of extrapyramidal side effects and dizziness. The benefit risk profile suggests that a dose of 1 to 3 milligram might be optimal for this population. So no clear-cut advantage was seen of a higher dose of 4 to 6 milligram versus 1 to 3 milligram in adolescents in schizophrenia. Regarding olanzapine study, in a 6-week randomized double-blind placebo-controlled study in which 107 adolescents participated from age 13 to 17. Olanzapine dose used for in this population 2.5 to 20 milligram per day. So it was not used more than 20 milligram. Efficacy measures were the scales used BPRS, PANSS, and CGI. Significant improvement occurred in olanzapine group versus placebo group. The major issue with olanzapine was weight gain versus placebo. One thing is important. We always say weight gain with some of these medications. It's important to remember these medications cause increase in appetite, which leads to eating more and then gaining weight. So there's only one way to gain weight, that you have more intake than output. So you're not burning calories as compared to how much you're taking in. And then there was increase in prolactin and triglycerides with olanzapine. Quetiapine study. This was again a 6-week randomized double-blind placebo-controlled study in which 220 adolescents participated. And two quetiapine doses were used, 400 milligram and 1800 milligram per day. Primary efficacy measure was the same scale. PANSS scores were seen. Significant improvement occurred in both groups, whether it was 400 milligram or 800 milligram. Weight gain was 2.2 kg with quetiapine 400 milligram and 1.8 kg with quetiapine 800 milligram. So no significant difference was noted in weight gain with the dosage. And then there was increase in cholesterol and triglycerides with quetiapine. Aripiprazole for schizophrenia. In this study, 302 adolescents participated aged 13 to 17. They were randomized to 10 milligram or 30 milligram per day of aripiprazole dose. After 6 weeks, both doses of active drugs resulted in significant higher rates of remission compared to placebo. 54% in low dose, 58% on high dose. So if you think about, and also in my clinical practice, if somebody is not going to respond to 15 milligram of aripiprazole, it's very unlikely that they will respond to higher than 15 milligram of aripiprazole dose. It was generally well tolerated. Extrapyramidal side effects were more frequent in aripiprazole than in placebo, especially akathisia, EPSCs, sedation, and tremors. And interestingly, in this group, no weight gain was noted with aripiprazole. One of the landmark study, treatment of early onset schizophrenia study, which was published in American Journal of Psychiatry in 2008. It was a double-blind study, and it was head-to-head study of olanzapine versus risperidone versus molindone for 8 weeks. The primary outcome was measured by CGI or PANSS scores. In this study, interestingly, no significant difference was found. In molindone, 50% individuals improved. In olanzapine, 34%, risperidone, 46%. With olanzapine and risperidone, higher rate of weight gain, and olanzapine showed the greater risk for weight gain and increase in fasting cholesterol, LDL, insulin, and liver transaminase level. And molindone, as we know, there are more risk of EPSCs. So as I already described in these studies, what are the major things you think about when prescribing atypical antipsychotics for side effects? Sedation, hyperglycemia, new onset diabetes, increased appetite leading to weight gain, and anticholinergic side effects like dry mouth, blurred vision, urinary retention. Prolactin levels, especially issues with risperidone, less with other medication, QTC prolongation in some atypical extrapyramidal side effects, increased lipids profile, especially with the risperidone, olanzapine, clozapine, and then clozapine leading to agranulocytosis, seizures, myocarditis. This is a chart showing that category-wise weight gain much more common with clozapine and olanzapine, extrapyramidal more common with risperidone, increased QTC interval more with ziprasidone, sedation more common with clozapine and olanzapine, and then quetiapine. Increased prolactin, the most common is with risperidone, and then with clozapine, risk of myocarditis, agranulocytosis, or seizures, and with quetiapine, possible corneal cataracts. So it's extremely important how we monitor for side effects in atypical antipsychotics. That we need to have baseline, and then at 4 weeks, 8 weeks, 12 weeks, quarterly, 6 to 12 months, and then every visit, some things to done, like personal family history for metabolic issues, lifestyle, what kind of lifestyle, exercise, if person is doing exercise, walking, what kind of diet person is taking. We check weight regularly, blood pressure, fasting glucose, and then fasting lipid profile is very important at baseline, at 12 weeks, and then every 6 to 12 months. So, what are some of the good prognosis with especially primary psychotic illnesses? If the onset is acute, if good pre-morbid functioning before the symptoms started, that there is a clear stressor which was present before the psychotic symptoms started, later onset, being female, minimal residual symptoms, especially after treatment, early in illness treatment response was robust with atypical antipsychotics, early intervention can improve functional outcome. And then some of the negative prognostic signs we should think about. If there is longer duration of untreated psychosis, high severity of positive and negative symptoms, especially negative symptoms, that there is loss of functioning and treatment resistance following repeated relapses, presence of residual symptoms, gradual onset, young age at onset. So all these are negative prognostic signs for recovery. So in summary, what we need in psychotic illnesses, well, we should have comprehensive assessment. The cause of psychosis, we should know whether it's medication, drugs, mood disorders, or primary psychotic illnesses. Psychoeducation to the individual family. What kind of antipsychotics we are going to use? Monitor the side effects closely, and then medications are important, but psychosocial interventions are also extremely important, that how we work with the child, individual, and family. So with this, I will end my presentation. It was a pleasure and honor to present at this conference. I wish everyone at the conference the very best, and inshallah, hopefully see you all in person at the next opportunity or a next conference. Thank you so much.